Panic disorder. Etiology and psychopathology. Panic disorder consists of recurrent bouts of intense and rapidly escalating anxiety associated with the unrealistic anticipation of imminent personal catastrophe. The condition is probably caused by the interaction between biochemical and psychological events, perhaps from a biochemical abnormality associated with poorly regulated autonomic responses. Patients with panic disorder are more likely than normal subjects to experience panic attacks when given yohimbine, an alpha-adrenergic antagonist, or sodium lactate infusions. Panic disorder is 5 times commoner in first-degree relatives than in the general population. Psychological factors. Patients with panic disorder are more likely than those with generalized anxiety disorder, GAD, to make alarming deductions from the physical symptoms of anxiety. According to this cognitive hypothesis, there is a vicious circle of fear that intensifies the autonomic response so that the patient interprets an increase in heart rate as a sign of an imminent heart attack, which in turn heightens anxiety and further accelerates heart rate. Epidemiology. There is a lifetime prevalence of 1.5%, with onset usually before the age of 40. There is a female-to-male ratio of 2 to 1. Clinical presentation. The patient experiences repeated unexpected bouts of severe anxiety that can occur in any situation and which are not restricted to certain places. The physical and psychological symptoms of panic disorder are similar to those of GAD, but are episodic and more intense. There is an overwhelming fear of loss of control and of imminent death, generally from a heart attack. As the disorder progresses, fear and avoidance of specific situations develops, generally of places such as supermarket checkout queues and public transport where the patient fears becoming trapped and unable to obtain emergency medical assistance. As the patient becomes increasingly housebound, the disorder might be more appropriately labeled panic disorder with agoraphobia. Differential diagnosis. Panic attacks can occur in the course of GAD, agoraphobia, depression, and alcohol withdrawal. The diagnosis of panic disorder depends on the characteristics and severity of the panic attacks, and on whether their onset precedes one of these other conditions. Treatment. Provide reassurance and explanation by describing the interaction between fear and overactivity of the sympathetic nervous system. Give the patient a simple diagram of the vicious circle that develops when fear caused by the physical symptoms of anxiety intensifies thoughts of imminent catastrophe. Benzodiazepines are to be avoided in the longer-term treatment of panic disorder because of the risk of dependence. Antidepressants have anti-panic effects. Cognitive behavior therapy. This is as effective as antidepressants and has a lower relapse rate. Antidepressants used include the following. Imipramine, low starting dose of 10 mg daily, a higher initial dose can actually exacerbate anxiety and insomnia. The dose is gradually increased over a period of weeks to about 150 mg daily. Be aware of cardiovascular and anticholinergic side effects as well as alpha-adrenoceptor blockade and the risk of seizures. Note that about 1/3 of patients with panic disorder relapse when imipramine is withdrawn. Selective serotonin reuptake inhibitors. Be aware of rebound anxiety when the antidepressant is withdrawn as well as common gastrointestinal and sexual side effects. Complications. Major depressive disorder occurs in at least half of those who have panic disorder. Agoraphobia is a common complication. Some patients become dependent on alcohol as a form of self-medication. Benzodiazepine dependence is not uncommon. Prognosis. The course tends to fluctuate. Even with treatment, 20 to 30% of patients with panic disorder are symptomatic at 6-year follow-up.